Hi, let's talk about shock. And one of the things that I want to say about shock is that it is an elephant. And how do you eat an elephant but one bite at a time? So we're going to go through these 32 slides to talk about shock. I will bring you something else to bring you a little more about shock, but you will be ready for the tests that you're going to take in this course, and also hopefully get you really prepared to start to study, but take the tools and the skills to get ready for your NCLEX. So let's talk about shock. I also share in this a little bit about my my personal, I feel like at the end of this semester, even though I've talked to you from the very beginning, I like to share a little bit because you're getting ready to graduate and things are getting ready to happen. So let's get going. Okay, I just want to show this picture. This is my youngest son. He played ultimate frisbee for the school and professionally, but that's him catching a frisbee. Always impressed. And look at the grass there. Love them. When I was a flight nurse, this was our base up in the mountains. Just FYI, let me find my little arrow. This is the actual fuel tank. We refueled there. This is the hangar. You can see the door and the people so you can understand size. And a door here that goes in. This is our living quarters, but this actually housed the helicopters in there. You can see the actual helicopter right there. You can see the blades. I always like to share a few things, but that's what it looked like. It was beautiful up there. We loved it. Okay, let's talk about shock. The definition of shock is something that you need to know. If someone says to you, what's the definition of shock? You need to be able to say this. And the definition is the lack of perfusion, which is blood supply, to tissues, which results in lack of oxygen and nutrients. It's a syndrome that involves all cells and their metabolic and chemical balance. That is what shock is. But if someone asks you the definition of shock, it's a lack of perfusion or blood supply to tissues, which results in a lack of oxygen and nutrients, which will result to what? Cellular death. So that's why it's so important that we are great nurses who assess, reassess, so that you pick up on signs to hopefully catch things in the beginning, because if you get through certain points of infection, of volume loss, of a neurovascular insult or trauma, if you get to this point and it started at this point at A and you're on Q, you're about way behind the 8 ball. And because of the lack of perfusion and lack of oxygenation and nutrients to the cells, cells die. And once you get to so much cellular death, we die. So that's why it's one of these concepts and a thought process and your critical thinking skill time to really kick in and get on it, so that you can hopefully reverse it and save your patient. Okay, hypovolemic shock is the first shock I'm going to talk about. And I want to say this to a lot of you because you guys are brilliant. Don't go into this extensive mass study on cellular exchange and you get into this big hoopla mess of shock. I want to back you up to the very beginning. When you're first learning shock, you need to learn basic things. You need to learn what we need to do and kind of get a good understanding. Then as you move forward in your schooling or career, you will build upon that. And when you get into an ICU, ER, different areas where it's critical care, that foundation that you have, you'll start to build layers and learn more and more and more. And then you will be a great, intensive critical care nurse. So, but let's get started. basic nursing. Hypovolemic shock. It is the most common form. So any significant loss of volume can cause hypovolemic shock. So we already know if we have a mass trauma and blood is going everywhere, we're losing volume. You see it. You come up on a scene, there's been a car accident, you walk up, you look, there's blood everywhere. Your first thought is, this patient's bleeding or there's been a blood loss and we're going to have a volume loss. But we can become hypovolemic and have hypovolemic shock with burns. And we just talked about burns. So if we get to a certain level, that full thickness where we have burned off the layer that holds the volume inside the cells, that holds the volume inside the tissue, and we're losing mass and sensible loss of volume, it's plasma that's leaking out, we can go into hypovolemic shock. Severe vomiting or diarrhea. If you vomit and vomit and vomit and it doesn't stop and you have not replaced your fluids and you just keep on, it keeps on keeping on, one, we're going to go into metabolic alkalosis from the vomiting, and we have a volume loss. If we do the opposite end and have diarrhea and we don't ever come off of the actual toilet and we have massive diarrhea, we're having a massive volume loss. Both of those are massive electrolytes and fluid and electrolyte loss. We can go into hypovolemic shock. And we know with diarrhea, we go into metabolic acidosis. That is correct. Internal bleeding. Sometimes we don't see it. These patients come in, they're pale, they're diaphoretic, they're cyanotic, their vital signs are unstable, and they just don't look good. And you're like, ooh, that doesn't look good. Well, it could be internal bleeding, and you need to ask them, have you ever had an ulcer? Have you ever had a GI bleed or something like that? Have you been going to the bathroom, and what does it look like? Because if it's a GI bleed, if they're vomiting, they can vomit up coffee grounds. They can vomit up bright red blood. If they're going to the bathroom, it can be a black tarry, or it could be a melanoma, where it's that purpley looking, but there is definite smell to both of those because you can't digest blood. So it gets a real, you won't forget it when you smell it. And if you have, you know exactly what I'm talking about. Or say we get in a car accident and I hit the dashboard, the whole body. I hit the steering wheel, which can cause another problem we'll talk about. But my legs go up under that dash, right? And my femur just smashes into it. And I actually fracture my femur. I can go into hypovolemic shock with internal bleeding of that, the fractured femur. Patients can bleed. That's a large bone, bleeds a lot. So we need to be very in touch and on top of our assessment skills, getting to the bottom of. It's not one of those things you take your clipboard in and la-di-da. We need to be talking. We need to figure this out. We need to be assessing, touching, feeling, talking to our patient. If they're unable to talk, then we're doing even more stuff, trying to get to the bottom of what's going on. I want to say this about external bleeding and internal bleeding or trauma itself. Mechanism of injury will tell you a whole lot. If you have a patient that rolls in on a stretcher and you're looking at them and you don't physically see a whole lot, maybe some bumps, a few bruises, some scrapes, scratches, whatever, but they don't look good, their vital signs are unstable, you don't see any deformity in bones or anything with the body, and but the EMS, our paramedics or EMTs, they come in and they go, look at what happened to this car, and they show you the picture. It rolled over 4 times, wrapped itself around a tree, and the speed was 150 miles per hour. Mechanism of injury alone can warrant you to think there is something really bad, traumatic that could happen. We can rupture spleens, livers. We can do a whole lot with trauma and have internal bleeding, especially with livers. External bleeding. External bleeding, we see it. It makes it easy. You can lay your eyes on it. You see it. It's outside the body. but we can have hypovolemic shock. There I am as a flight nurse, my dear friend Billy and partner. We had some good times. Assessment. You will need to resuscitate the patient and assess at the same time. Now, I want you to look at this injury. I put it on here. Do you see any obvious bleeding? Yes, we do. And how much volume do you think they've lost? I'm going with quite a bit of volume loss. So we are looking at definitely a patient that could go into hypovolemic shock. And in this situation, if it is a blood loss, you want to give blood. You can only replace for so long a non-blood product, fluids or whatever, volume expanders to help this patient through the crisis state. You can only give so much of that because eventually if they're losing blood, they've got to have blood, or you just deplete the blood system and you can't live without it. So that is so important. And I also want you to think about this just for a second. If we go back to that definition, and there is a lack of perfusion and a lack of oxygenation and nutrition to cell, and that equals cellular death, then what carries our oxygen but red blood cells? So if we deplete all our red blood cells, we have nothing to carry oxygen. We're going to be in hypovolemic shock. But think about this. If all the blood's all over outside of the body or inside the body, but not where it should be circulating through the body, then how are we going to carry oxygen through the body? We're not. So if you constantly are throwing volume, and you will infuse a lot of volume. If you're constantly infusing volume, normal saline bags, lactated ringers, if we're doing, albumin, whatever, if it's a non-blood product, if it's non-red blood cells and red blood cells are coming out, we're not going to have the oxygen carrying capacity with what we get with red blood cells. So in a nutshell, you lose blood, you replace with blood. You lose blood, you replace with blood. Simple as that. What to do? In those situations, you go, what do I do? People that are not trained to do things sometimes can kind of kick in and understand I better stop something from bleeding, so they'll put pressure on it. But for a person that's in training, a nurse, a paramedic, any kind of medical professional that works and deals with these kind of situations, you want to stop the fluid loss if possible. Now, that doesn't always mean you can, but you want to try. You've got to stop it. If it's coming out, if they're losing volume, then you've got to stop the volume loss, because if not, they're going to bleed out or lose enough volume. Say they're vomiting, you got to stop the vomiting. If they're having diarrhea, stop the diarrhea. If they're bleeding out, put pressure on wherever that blood is. Go ahead and secure it, put pressure, stop bleeding, especially arterial bleeding. They'll bleed out in minutes. So we want to stop the fluid loss if possible. Now, if we have mass burns, are we going to be able to stop that fluid loss if they're mass, the end of partial thickness going into full thickness, the end of that secondary going into third degree burns? Fourth degree burns, are we going to be able to stop that insensible fluid loss? No, you're not going to be able to. So what do? I'm going to just do a little review from burns. We are going to quickly assess the burn. We are going to do the rule of nines. We are going to get a percentage of the burn on the body. Then we're going to use our Parkland formula. We're going to use the Parkland formula. And then we are going to calculate how much volume needs to be replaced. We're going to be on top of it, giving that first half of that volume that we get out of that calculation in 8 hours from the time of the burn. And then the next 16 hours, once the 8 hours is ended, then the next 16 hours, we'll give the second half of that volume. And in 24 hours from the time of the initial burn, 24 hours, we have fluid resuscitated that patient and hope to get ahead of this hypovolemic shock, ahead of the fluid loss, that insensible fluid loss. So there's your little review on burns and volume. We want to start large bore IVs, preferably 18 gauges or larger. If you work in an ER and a trauma center, you will be used to using 18 gauge catheters, IV catheters. I actually have put in a few 16s. I've never put in a 14. For some reason, I haven't had to have one, even in all the trauma that I was involved with. 14 gauges to me look just cruel. So it's not going to happen on my end. But an 18 gauge or larger. Don't try to put a 24 in an adult and think you're going to be able to give mass volume blood or anything else. It doesn't work. Now, can it work? I'm not going to say it can never, but you're setting yourself up to get behind the 8 ball, because if the IV fails you, then you're not going to be able to replace the volume. And you need a large bore IV to give blood products. So 18 gauge or larger. If you absolutely can't get it in, you can use a 20. And if you really are having problems putting in any kind of access, have the physician please place a line. So you want to set up to assist the MD in a central line placement, because that's the ticket. You want a big kind of line that you can do anything with. You want to give a lot of volume. It's there. You can access off of it if you need to for labs, whatever. And because what happens in hypovolemic shock, we'll start to get cellular collapse. We'll start to get vascular collapse. And when we have that vascular collapse, it's hard to get an IV in a patient. I mean, if you've never really dealt with it, but if you had ever deal with a really dehydrated patient and starting to put IVs in, it's very difficult, because you start to have this vascular collapse due to the lack of volume, again, circulating volume. They're dehydrated, dry, so it can get sticky. In hypovolemic shock, I always want to bring it back. In hypovolemic shock, we want to put a large bore IV, 18 gauge or larger, and if not, help to set up to put in a central line, which the physician would do, or practitioner now. While waiting on blood from the blood bank or other fluid, these other fluids that can be used, you can hang 0.9% normal saline. That is normal saline, 0.9%. You can hang LR, lactated ringers, or ringers lactate, you'll see sometimes. Albumin, and there are other volume expanders out there that you might get an order to use, but these are ones that you see quite a bit, or these are the things you'd want to do. If I have a patient coming in, I automatically would have a liter of normal saline already spiked, ready to go, and hook to the patient and start giving volume. That's why if you go into an ER and there's a trauma, you'll see mass bags of volume hanging. They are giving volume if needed. They can turn it off if needed, if the patient can't handle it, or you don't need to give that kind of volume. But please, let's go over it one more time. What to do: stop the fluid if possible. If it's vomiting, stop vomiting. Diarrhea, stop it. Bleeding, stop the bleeding. Can't do insensible fluid loss due to burns, but we can give the volume resuscitation and get ahead of the game. Replace that volume immediately as soon as you can. Hang stuff in lieu of, if it's blood you need, while you're waiting on blood bank to process and get blood to you, go ahead and give that volume, normal saline, LR, albumin, whichever the physician orders or your protocols ask for. Start large bore IVs, 18 gauge or greater, set up for a central line with the doctor, and just be ready to give that volume, because that's what fixes hypovolemic shock, is replacing the volume that's lost. Stop the problem, replace the volume, and you need to be doing this at the same time. This is where it gets sticky. This is where you have people helping you, but you need to be thinking, critically thinking. I have a patient who's been in a motor vehicle collision. They're coming in. I know that they have a deformity to the upper right thigh area. My thought is they've got a femur fracture. EMS is doing their thing out there. They'll probably come in and have traction on it. We know we've got a pulse, but say not. Say it happened right across the street. They don't have time to do all that. They're going to scoop and run, get that patient into your ER. You look at that and you go, oh, you get that in code. You get a call in and EMS is on their way. And they're going to say, we've got a deformed femur. I'm immediately going to think, okay, I know if I have a fractured femur, I can lose liters of volume into that thigh. I could be internally bleeding out in a matter of minutes, be at death's door. I need to replace that volume. So I'm going to go ahead, in lieu of even assessing the patient, have a normal saline spiked, ready to go, let the physician know what's coming in, and even maybe have a volume expander on standby to be able to spike and give quickly. Don't panic. Take a breath. Take a breath. I'm going to move myself really quickly. Let me find me. Here I am. There we go. Do not panic. Take a breath and assess. A, B, C, D, E. A, airway. B, breathing. C, circulation. D, disability, meaning neurological status. Let's do an assessment of their neurostatus. It's so important. We have unequal pupils. Do we have, can they tell me their name? Can they tell me their birthday? I might not be able to compare it to anything. What year is it? I know what year it is. Can you, hey, what year is this? What season are we in? If it's Christmas time, tell me what season, tell me what holidays coming up, whatever. It should be triggers for people to be able to answer you correctly, and you can get a little assessment of the neurological status. If they're able to follow you, are they looking at you? Are they off in a daze? Or do their eyes move and focus and do? Can they move their mouth? Can they, smile? Stick your tongue out. E, expose. Environmental controls is also in that. So remove the clothes, but keep them warm. We don't want a patient to get cold. We need to keep them warm. There's a reason. If we go in and it's cold because you're burning up because you're working, but the patient is already in distress, we already have the cellular perfusion, oxygenation issue, lack of perfusion and oxygenation issue going on. And because of that, neurologically, things can happen. We start to do different things and we can get cold. That is going on into a different state of shock when we get into, the patient gets into the cold stage. Cold is dropping below, like into the 97s. You get down 97, some of you might live 97, 8, 97, 9, very rare. I live on the lower end of the 98s in the high 97 world, like 97.9, 98.1, 98.2. I'm not a 98.6 person, but you get to 97, 96. It's not the temperature a patient should be. We are then going into a different shock, and we'll break those down, but we're going into a different stage of shock. And when we're getting to that shock, it's getting towards the end. It's getting to where we can't reverse it. It's irreversible shock. So we want to make sure we keep them warm. Expose them though, because you need to look from head to toe of the entire body. We do a quick head to toe assessment. We're going to scan the body, arms. We will turn the patient. Everybody, if it's we suspect a spinal cord injury, we will have someone holding C-spine, we'll have C-collar. We'll protect the C-spine, turn the patient, do an assessment, sweep the back. You want to look at that patient front, back, head to toe very quickly. It's an expose and look, because you've got to treat what you see, what's going on with this patient. It will speak volumes to you when you can see. It's like reading a book, trying to get to the end so you can see what happens. Now we do it CAB style. Let's talk it about again. The reason why I say that is, we always said ABCs, ABCs, and we still will tell you ABCs. You need to think airway, breathing, circulation. But what we do in CPR now is circulation, airway, breathing. We will immediately check for a pulse. If there's no pulse, then we will start compressions. And then we are looking at airway and breathing. We do it CAB style. Do it CAB style. I think that's a song somewhere coming. When giving blood in an emergency, I want to bring this back. You have learned all of these things. You have gone over this, so it's like almost a review again, but I want to say it to you again because it's so important. It's life. It can be life-threatening if you give the incorrect blood to a patient. We don't want to make those mistakes. It can be life-threatening to not give the blood to the patient quickly if they need it. So don't forget the verification process. Match your blood product to the order. Match the patient to the blood product. Use two-person verification process Wrong blood product, bad outcome, period. They have the blood verification system set up to hopefully help you. Some facilities that I've worked in have the system that you scan. You have your scanner, you scan this, you scan that, you scan the blood, you scan the form that's on the blood, you scan the patient, you do all these scans. It gives you green checks, check, 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 check. When you have all the checks, then you can put in, and it should be allow you to then administer the blood. Now, I'm an old school nurse. I've nursed for a long time, going into 27 years. So right at 27 years. So in that situation, I'm going to tell you old school wise, you get a person with you. It's a 2-person check. Hey, come here. You want them standing at bedside. You're going to look at the blood. You're going to compare it to your order. If it's on a computer, if it's on the chart, whatever. You're going to look at that order. Is it correct? I'm going to transfuse A positive blood. This is A positive blood. We're going to look at it. Then you give the paper to them. You're looking at the blood product. It's the paper that comes. The blood bank will release with it. And you're going to go through the checks. There's all these numbers. Does that information match the information that's on the blood product itself? And you go through those checks. We're checking the patient, we're looking at ID band, we're looking at the order, we're looking at that. It is a check, 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 check system. Please, I cannot say that enough. Do people still give blood or hang blood incorrectly? Yes, and I'm gonna tell you how they do it. You would think, how with all that, Ms. Bilal, how? And I'm just gonna say this, is how is, in an emergent situation, you can give uncrossed, unmatched blood. You can, uncrossed blood. They'll send you, blood to hang, the universal. And so you can just pop that stuff up and not think about it. Sometimes we're humans, we make mistakes. Things can happen. Double check, double check, double check. I mean, I'm gonna just go ahead on record to say this. How do we still cut off the wrong part of the body in the OR? Because we don't do the timeouts and do the checks. We don't have where they X the correct area and we ask the patient, what are you having done? There's a process in place because mistakes have been made, and it's to save your patient, number one, and to save you, number two. So please get the right blood. Volume loss, what happens? When we start to lose the volume, what happens? We're going to have a decrease in circulating volume. And let me ask you this, if we have a decrease in circulating volume, what is going to happen? Our heart rate's going to go up. Our heart's going to go, we need to pump more. We got to pump. There's not enough volume. We need to pump up the volume. So anyway, decreased cardiac output. If we don't have enough volume, our cardiac output, which is perfusion, is what's pumping out there, that cardiac output, if we don't have that, we don't have an adequate cardiac output, we have a decrease in it, then we're not going to perfuse, period. It's just how it works. So you got to have volume to do this. If the blood pressure is going to lower, and when that happens, we're going to stimulate the sympathetic nervous system. Our heart rate's going to go up, and our vessels are going to start to clamp down. Now, think about it like the old hose, right? If I have a hose and I have it wide open, and I have it wide open, and I'm watering the garden, and the water's just spewing out. I mean, it's beautiful. It's beautiful. It's hot here right now in summer. I have my hose is completely open, flowing, no issue. If I have a kink in my hose, the hose over by, it's just kinked slightly, am I going to have the same amount of volume coming out of that hose? No, I'm not. It's going to be half of that, right? Because it's a slight kink. There's still volume coming out. It's just not as much. It's just kind of, so I can't hit the back flowers. I can only get the front because I don't have enough flow to get back there, right? Even if I put my thumb on it, I just can't seem to get it. So it's kind of kinked. That's how you should think about a vessel, a blood vessel. It's like a hose. So if I have a hose and I have all the volume going through it without any problem, I've got the hose turned on. full volume. Volume's coming through. If I have all of a sudden a truck runs over the water line, I will have a decrease in volume, right? In pressure and volume. When I have that, the vessel will still be, my hose still wide open, but I am only filling the hose up like this, half full. So I'm not getting as much volume through to come out. So I'm going to have this little small, and if I kink it slightly, it gets a little less, right? So I'm trying to start. So in our vessels, we go, ooh, I don't have enough volume. I need to start to constrict because I have to perfuse. I need to be pushing volume. That's why I'm going to constrict. So I'm going to break this down really quickly, one more time. So if I have a volume loss, I have this decrease in volume. I've either thrown it up, I've had diarrhea, I have a severe burn, or I have blood coming out or blood pooling in, but it's not in the system where it should be. If I have that volume loss, then my sympathetic nervous system is going to kick in. My heart rate's going to go up. My respiratory rate will go up too, by the way, because I'm going to try to oxygenate, bring in more air. I need to breathe. I need to oxygenate. Let me get some air in here. I'm going to have a blood pressure to go down, and my vessels will start to clamp down to try to shunt volume to maintain brain, heart, major organs, but brain and heart. When it gets to a certain level, the body will still continue to try to do brain and heart, but it won't do kidneys, it won't do the GI tract, it won't do skin, it won't do those other organs because it doesn't have enough. So it's going to know, the body knows, I've got to save the brain, I got to save the heart. And we have inadequate tissue perfusion when we have the sympathetic nervous system kicks in because of volume loss. So when we have hypovolemia, we have inadequate tissue perfusion, period. When do I give blood? When a patient's losing blood. Simple. Large bone fractures. These big bones in our bodies, pelvis, the pelvic area, the pelvis, it's a big bone. The femur, if they fracture, you're going to need to give blood. It's a given. They bleed. Gaping open bleeding wounds. That's an easy. That was like that picture that we saw earlier. Internal bleeding. Now I'm going to tell you, GI bleeds, which is vomiting blood or defecating blood, or internal bleeding. We've lacerated the liver, the spleen, there's been an internal organ we've damaged and we are bleeding internally. In that case, we need to give blood. If we have a GI bleed, and I want to talk about this because a lot of you, when you come out of nursing school, will probably see GI bleeds before you might see a big long bone fracture. GI bleeds can get the best of you. You've got to understand how dangerous, how critical the patient can be with a GI bleed. If you have a patient that comes in and they said, I've been having bloody stools I woke up last night, went to the bathroom, had a bloody stool, and I've had 4 bloody stools. I don't feel good. They look pale. They're diaphoretic. They just don't look good. They're tachycardic, or blood pressure's on the lower side. If you have this person, they come in, they're still stable. They're still looking like, oh, let's clean you up. Let's do that. You will be behind the 8 ball again. You will be behind this, not in front of it or not on top of it. And the reason why I'm saying this is because if you think about it, if they've had 4 to 5 bloody stools and then they come in and they have a big bloody stool for you in a bedpan's full, think of the volume loss. And it is that melena, I never say that right. It is that bloody purpley looking dark hued stool, and there's a foul smell to it. If you've got that, they have lost a lot of volume already. And so you need to be what? going ahead and getting an order to type and cross the patient for however many units that the physician thinks, getting a stat, CBC, let's look at the hematocrit, hemoglobin and hematocrit, let's look at the red blood cells, let's look at the picture here, what's going on, and work accordingly. So don't think just because they're going to the bathroom and it's that it's not critical or it's not serious. We had a patient once a long time ago, I'll never forget it. I was travel nursing at the time, and the patient came in and she didn't look good, but she had a couple very large bloody stools. And she said, you know, she was sick. Her stomach was hurting. She was sick. She goes, I'm going to have to go to the bathroom again. And we put her on the bedpan, and she filled it to the rim. And it was that bloody liquid stool. It wasn't actually my patient. I came in to help. And I said, have we sent down a stat H&H? And they said, no. And I said, have we called the physician to tell him what's going on? No. Do you think we need to go ahead and call? And I'll go ahead and start to get a type and cross match this patient. Let's get an order for that and get that sit down stat. And they were real slow. And I finally just looked and said, I'm going to say this. We stepped outside the room away from the patient. I said, I'm going to tell you this. If you don't do these things quickly, she's going to start to go bad very quickly. And it's going to be irreversible, because we're really right there on the brink of her going to code if we're not careful. And it was a new nurse, and they got really going. And I said, I'll be back to help you here in a minute. I've got to go take care of my patient, and I'll be right back. And I asked for someone to go help them, and they did. And ended up, the patient actually did go in, you know, cardiac arrested, coded, and passed away. But if we had not interacted when we did, we would have had that happen much earlier. Now, she could have come in earlier. We could have probably reversed it. It's one of those deals. Anyway, be on top of it. That's the point. What happens when the sympathetic nervous system is stimulated? Well, the heartbeat gets faster and harder. We're going to try to pump up the jam. Vasoconstriction. We're going to constrict. Vascular. Vasoconstriction. We're going to constrict. Pupils will dilate. The bronchi dilate to increase your airflow. We're trying to perfuse, okay? We're trying to oxygenate and perfuse. The liver breaks down stored sugar. We need energy to do this. We've got to. We're burning it. We're burning it up because we're trying to survive. So our heart rate goes up. Our pupils are going to dilate, that fight or flight type response. We're going to have our bronchi are going to dilate to increase airflow. So we automatically dilate so we can get more air in. We're breathing. Liver breaks down that stored sugar to help provide energy for this stuff to happen. We need it. Okay. I want to stop there, and then I will pick back up in the next video on cardiogenic shock. See you soon.